Well, while that's happening, I'm trying not to keep staring out the window. This is a pretty remarkable place. I live outside of Baltimore, in Annapolis. So being here today is a little different. So my job today is to talk a little bit about a national perspective. But before I do that, I just want to talk a little bit about why I'm here. I'm honored to be able to speak with all of you today, and I'm honored to really have a chance to participate in this important conversation. Jackson has always been a special place for our family. We vacation here a lot. That's where my kids developed their addiction to skiing, and my daughter Kate lives here, and that's really where I want to start my talk, because I'm here as an AHA board member. But the real reason I'm here is because I care about the health in this community, because my daughter lives here. And so I have a very personal reason to be talking here. And I want to use a bit of Kate's story to talk about what you're going to hear about later today, and that's access to care. So my daughter Kate came out here in 2011. Many of you met her. She's down there handing out badges. And she was here for a year. How many of you have either personally experienced that or have kids that have done that? They come here for a year, and now it's 2015, right? Right. So she came here in 2011. 2012, she got really sick. She developed a very unusual infection, and she ended up having sepsis. And we ended up having to have her air evac to the University of Utah, where we had her stabilized and cared for, and then brought her back to the mecca of medicine. I wish you wouldn't say planes go only to Mayo. They do go to Hopkins. And we brought her back to Hopkins, where she spent several weeks. And 2 months later, she was ready to come back. Now, being the good parent, loving this place, but being concerned about access to care, I was a little bit concerned about that, because while we had treated her infection, we still didn't know what caused it. You never want to be the case conference at Utah and at Hopkins. That's not a place you want to be. And so I was pretty concerned. And I wanted to make sure that she had an internist. So I went online, looked it up. There were 3. She wanted a female internist. There were 3. And then I went to what I know is a trusted organization in many communities, the hospital, to say, okay, are these people involved? How do I get a sense of the quality of the physician that I'm going to try to have my daughter cared for? And lo and behold, there was this little pop-up there that had this picture of this guy that I had worked with 30 years ago, Dr. Hoheiser, and he was being announced as the new president. And immediately I felt a sense of relief, because now I had a personal connection, somebody I trusted who could help guide my daughter. And Lou, you were incredible in helping Kate, getting her health insurance and all that other good stuff. And what it reinforced to me and made very personal is that in places like this that are so incredible and so wonderful, we've got to make sure that we've got systems of care. And so I'm clearly doing this talk from the perspective of self-interest, and I would believe that everybody that's sitting in this room today shares that as a common perspective. But I also believe as community members that you have shared interest. And the beauty of this kind of gathering, and as an AHA board member, I get to participate in conversations like these across the country, is that you're coming together to take your self-interest, develop a sense of shared interest, and what you're going to hear about today, based on the Community Health Needs Assessment, is a structure to try to move this conversation forward so that this becomes a model for a healthy community in a rural setting in the United States. And as a trustee of the American Hospital Association, I'm really excited about participating in this conversation. And my challenge to all of you is to take your self-interest, turn it into shared interest, Work with your hospital, work with your health department, work with your local providers in your community to be able to really take this special place where special things happen and make healthcare that centerpiece, so that when other college students from Colby come in and get sick, there's a system of care here that everybody has confidence in. And it doesn't require me seeing the picture of an old friend doing that. And so that's really why I'm here today, is that connection. So today's discussion is something that we're going to give you a sense of a national perspective here. What's going on in healthcare and why? What are the challenges that communities are facing, and how communities and hospitals and health systems are adapting. Now, as I said, I get an opportunity to go around the country and have these kinds of conversations with organizations and communities. And there are a lot of points that are consistent in these conversations. The first is that this is a significant period of change in healthcare, probably more so than I've seen in the 30-plus years that I've been doing this. The second is that now more than ever, it's important for communities and hospitals and healthcare providers to come together to collectively work in a way to assure that their communities have access to great care. Because when I go around the country and you ask, what's the single thing that you're worried about? It's access to care. It's having the system available in whatever form you need when you need it. And I describe that as getting the right care at the right place at the right time, and in this evolving environment at the right price. And so that's what we're going to talk about today. So what's going on? And just to give you some context, the US is spending more than any developed country on healthcare, and we're getting, at best, mediocre results. Now, I could do a whole talk on that and show the health indicators, but that's a problem. We're spending more, and our results aren't great. Now, business leaders, government payers, community members are demanding that the health system become more accountable. But at the same time, we're aging. We're living longer with more chronic conditions. And the baby boomers have an expectation that they're still going to do backcountry skiing into their late 70s, right? And so when you mix those things up, right, we've got folks that want to find the fountain of youth and keep going. And to some extent, we are. Certainly, technology is helping, but there is no magic bullet. And so how do we put together a system of care that allows people to continue to self-actualize and do so in a way that meets their needs in their communities? Now, there is other structural change that's occurring in the healthcare system. And one of those changes is in how Medicare and Medicaid has been funded. And this is the part where you can get really bogged down in the politics of healthcare, and depending on what your point of view is on this. But the reality is that the passage of the Affordable Care Act accelerated that transformation. Whether you like it or not, whether you think it's going to go away, whatever the court determines, the reality is it accelerated that. But that was already in existence. This notion of how do we get better value and better access and better quality was already underway. Insurers, business leaders, and others, as I've said, have taken this under, and we've already seen this movement. And I would argue that regardless of what gets tweaked or changed with the ACA, this change is here to stay. Now, there are some good things about this. It expanded healthcare coverage to almost 25 million more individuals. It adopted payment system reforms, and I'll talk about that in a little more detail. But it had some negative effects, particularly to healthcare organizations like St. John's, in that it reduces Medicare and, in some instances, Medicaid payments. And at the same time, there are many other pressures that are affecting those organizations. But I view this as an experiment. And there's a lot of demonstrations that are going on through the country to try to figure out what this right system of care is. But as my colleague Lou noted in a conversation I was having with him yesterday, that this is just the start. That real change can only occur when we look at not just the health care that's provided, but the social determinants of health. And that's why community conversations like this are so important, because it brings together the pieces. You know, talking earlier, it's about housing, right? It's about safety net services. It's about food. You know, if I look at what's happening in Baltimore this week, you know, it's not just about a horrible incident that occurred. It's about a whole series of things in our community in Baltimore that we haven't been able to address. And that's why these community conversations, again, are so important. So what is this thing that people talk about, health transformation? You know, I think many of you have heard about, you know, we're moving from volume to value. And what we're saying is that the payment systems now are moving from how much we do to how well we're doing it. And that's causing a lot of change in the delivery system, because we're used to being paid on everything that we do. And sometimes when we don't quite get it right, we get to charge again. And you know, that's an unusual circumstance, right? So that's changing. In the past, hospitals and doctors were paid, and post-acute were paid separately. Now we're seeing opportunities to bundle payments and deliver care in a more coordinated way. And then historically, we've been paid focused on an incident of care. You need a hip replacement. Now we're going to be paid, and we're doing experiments in Baltimore on how we take care of a patient over a period of time. So just for the sake of time, I won't go through all of these attributes, but there is one that I'd like you to think about. We're moving from a point of bricks and mortar to systems of care. One of the observations I have about St. John's is you guys have a health campus there. And then Lou said to me, yeah, but that's not enough. We've got to get outside of the domain of the property that we have and serve more into the community. And that's really what we're talking about. Individuals are becoming more engaged as consumers. And you know, we always talked about patients having skin in the game. Well, with these payment changes, particularly with the development of exchanges, which is the single largest growth area of health insurance, now all of a sudden people are making choice, and they've got more out-of-pocket costs, and they're becoming better consumers. And so the conversations that are starting, particularly with providers, that sometimes are unsettling is, gee, doctor, do I really need that second MRI? Or people finally realizing what the prescription drugs actually cost. And you know, maybe I need to do something about my weight or my levels of activity in order to not spend that much money. So this shift can be very disruptive, particularly as new entrants are coming into the healthcare field. And the other thing that we need to understand is that it's not uniformly applied. As I get to see this throughout the country, this pace of change, if it even exists, is varied. When I go down to Louisiana and start talking about value-based care, I don't get my coffee filled. So, you know, it's a different conversation when I go to a community setting in some parts of the country. So in summary, if you think about health reform and what's going on right now, in my simple way of looking at it, hospitals and doctors are going to get paid less and differently. You're going to see more financial risk being shifted from traditional payers to providers. More people are going to be cared for that have some mechanism of payment, but that mechanism of payment is going to be more like Medicaid and Medicare and not what we all know as traditional commercial insurance. And probably the most important thing is that patients are now going to start to take more control over decision making. And I think that that is probably one of the best things that can happen through this change process. Now, rural organizations have a particular challenge. Recently, I sat through the the American Hospital Association is broken into 9 regions, and that's how we get our information fed to us as a board. And as board members, we have to attend the meetings in each of those 9 regions. And I went to RPB 8, which are the frontier states, right? And boy, did I have my eyes open. I work in an organization that has 41,000 employees. I had dinner with a president of a hospital in New Mexico, 10 beds. She has 42 employees. That hospital needs to exist because there isn't another place for 150 miles. Same kinds of challenges, but the base is so much different. There are a number of other attributes that you can all tell me about, but if we think about the dependence of rural facilities on Medicare and Medicaid, these changes are particularly scary. The other issue is when we start talking about value-based health and bundling payments and population health and assuming financial risk, when you have a small number of patients, that's really hard to do. And so the work that we're trying to do at the American Hospital Association is to make sure that the voice of rural medicine is heard. And that's why it's been particularly encouraging for me, coming out of an academic health system, to be engaged in these kinds of conversations, because I believe that I can bring that voice to the table, because a lot of this has to do with policy changes and common sense. So what we're doing at the AHA to try to address some of these concerns is that we're trying to make sure that the funding is protected and that the funding sources are protected. The second thing that we're trying to do is to make sure that the regulation makes sense. And that's not easy. Because once again, the voice is small of rural medicine. February 2nd was a big day for rural medicine. A lot of bills were dropped that day which begin to address some of the concerns. But the importance is not the dropping of a bill, the importance is ultimately securing the kinds of changes that need to take place. And so we are very involved in this conversation. It's important that as board members we get out and we see this so that we can hold our leaders accountable. And once again, I'm very happy to become one of several voices of rural medicine at the table. If you start to think about the changes that are occurring in healthcare, you really need to have some sort of a framework. So several years ago, when we were negotiating with the Obama administration about what was going to happen through the ACA, we adopted as a method of thinking about this the triple aim. And this was taken from some work that was done by Don Berwick, who many of you may have heard of. He headed up CMS for a brief period of time. But the more important work he did after he finished his career as a pediatrician is he worked for the Institute of Healthcare Improvement in Boston. And it really became what I would call the honest mirror in healthcare about quality and how we need to improve quality. And so he developed this concept, or the IHI developed this concept of the triple aim. And really what it's about is improving the experience of care for patients. And that means that the care that we provide is of the highest quality. It means that we are involving patients and families and their care teams in decision making, and that we're listening and learning. It also talks about thinking about health from the standpoint of populations, as opposed to only the individual transactions with patients. And having a strong focus on prevention and wellness, because ultimately those aspects, preventing disease, is really what's going to drive down the other aspect of this, which is per capita spending. Because remember at the beginning of the talk, we're spending more than any developed country, and we're getting, at best, mediocre results. So this was the framework that we moved forward with the conversations that we've had with both the Obama administration and the Senate and the House. This is our star that we tend to go back to each and every time when we're trying to sort through complex decisions. But there are implications of adopting this triple aim to hospitals. Because once again, you go back to getting paid less, seeing risk shifted, having to take care of more patients in a more consumer-oriented environment. So to meet the triple aim, hospitals are having to adjust and shift. And there's a tremendous amount of pressure right now on the 5,000 hospitals in the US to begin to adapt to these new methodologies. In the state of Maryland, we're under a global budget now for hospital spending. It's indexed to the state gross domestic product. I didn't even know the state had a gross domestic product until we began this. So we have to keep our spending under a cap for hospital services, and all of a sudden it's changing the conversation. So this experimentation, it varies by market and it's different, but we see a lot of different ways of addressing this from hospital standpoint. One is that some organizations are thinking about specializing, and they're dropping services and they're limiting services. Others are partnering. They're either creating alliances, strategic alliances, they're merging, or they're affiliating. I can't tell you how many conversations I'm having with folks who want to become part of the Johns Hopkins Health System. They're redefining the system and the way the system needs to be designed in their communities. And they're moving from this concept of a hospital being a place where patients stay to a place that is a convener of healthcare. There's a lot of experimentation going on. I described the experiment we have in Maryland as a state, but we're also looking individually at how we develop systems of care locally. We're doing some really interesting things with some of our community populations where we are helping people stay well with incredibly complex and chronic diseases and horrible social circumstances. That was one of the things that was most sad the other night when I saw the senior center on fire in Baltimore, because that's one of our areas of effort where we work with our community. The pleasant thing was the next morning getting up and seeing the community come together and begin to clean up and rebuild. And that level, once again, of community involvement is going to be really critical. And then we're seeing organization integrating. If you look at Johns Hopkins, we're about a $7.2 billion company, right? $1.4 billion of that is an insurance plan. So we've become, in essence, an insurance company attached to a health system. Now, once again, all places can't do this stuff. You've got to pick and choose what you need to do. And once again, this needs to be driven by the community. Hospitals are doing many other things to change. You know, across the country, you're seeing an increased focus on efficiency and operations, really thinking hard about the services that are being offered. We've got 2 hospitals that are 5 miles apart, one in Washington, D.C., and one outside. It's like Noah's Ark, you know. We do 2 of everything. Well, now we're starting to think about that. You know, we're starting to say, well, do we really need to have 2 programs that are exactly the same 5 miles apart? We are focused on really becoming value-added in how we work with community-based organizations to, once again, not duplicate unnecessarily. And we're trying to make sure that we've got strong leadership and connections at the community level. But one of the things that's most important is flexibility, because one size, as I said, doesn't fit all. So as we look at possible models, and each of these organizations are doing this, and once again, I see this as my travels, we need to take into consideration what the community needs and how the community is engaged. For example, you know, rural communities in some instances may not have the ability to experiment. They might not have the resources. Once again, when I was at the Regional Policy Board 8 with the frontier states, to think about that hospital in New Mexico with 42 employees to engage in a kind of experimentation on assuming financial risk, Probably not, right? And when you talk to them about population health, well, that's what they do, right? Right? So how do we begin to translate what the government is enabling and thinking about in order to have it make sense? But we are seeing rural organizations doing some really interesting things and developing new partnership models. But once again, it differs by the community that you're in. And here in Jackson, I think you have the ability to really do something special. I have been just so impressed with the quality of people that live here and that I've interacted with. And the staff, Lou, you have is just awesome. Really, I want to hire several of them. But you told me last night, don't dare do that, right? So, you know, in this valley, there's a wealth of talent that can come together to, I think, really do something that could become a model for the country. And that's, once again, why I'm so excited about being here. So in the past 30 minutes or so, I've you know, tried to give you a lot of information. But what I wanted to try to tie this back to are what we're going to be discussing here at today's forum. You know, there are going to be many paths for communities and hospitals to take as they adapt to the changing healthcare system. But the most important piece is it's critical that they work with their communities to determine what the needs are and how to best serve the communities. Because ultimately, communities are going to need to see hospitals fighting for them if we expect to see, right, if we expect to see communities fighting for their hospitals. Because what's happening across the country, particularly as a lot of new money is coming into the healthcare system through private equity and other things, we're starting to see an erosion of that core hospital. It's getting picked off. There are 72 surgery centers in the market area of one of our community hospitals, okay? I'm not saying that's good or bad or right or wrong. Most of them are investor-owned. But when that happens, it puts an incredible burden back on the hospitals because, you know, those places aren't there 24/7. Those places aren't there when all else fails and a safety net needs to occur. And so as we think about this, and we want communities to fight for their hospitals to support them, we've got to make sure that those hospitals are fighting for those communities. And once again, a conversation like this is so critically important. So hopefully I've given you some perspective on what's happening nationally. I know I've downloaded a lot of information. But if I could only hope that you'd walk away from this talk with one thing, it would be this. A hospital is not the center of the healthcare universe, but it is a trusted resource. You know, the blue H, when you go into a community and you see that sign, kind of gives you comfort. It's like seeing an old friend on the website and knowing, you know what, my daughter's going to be okay going back there. It's that trusted resource. And it's recognized as a credible brand. Because what it means to many folks is it's that safety net. It's that point of relief. But that being said, it's not the center of the universe anymore because most healthcare, fortunately, takes place outside the walls of a traditional hospital. So later in today's program, you're going to hear about the Community Health Needs Assessment. And I don't want to steal your thunder, but one of the things that you told each other through that process was that access is really important. So if I can underscore one thing, and that is the hospitals that are convening these kinds of conversations with the community, it could be viewed as self-interest and we're just trying to, you know, kind of keep the hospital where it is. But I would argue in many communities, and the experience I have had in the past few days here and knowing Lou, that this isn't about preserving the status quo. This is about how do you improve access to care so that this community is as vibrant as it can possibly be. It's developing models of collaboration, and it's becoming something that can be a national model. Thank you for all of your time today. 5 hours out of your time to come here on a beautiful day like this, take your time away from work, is really important. And Lou, you ought to be thrilled you've got this kind of engagement. Thank you all very much.